Okay, we're gonna start just a couple minutes early in the hope that we can get it through introductions very briefly. So most of you were already in this room. I'll just tell you, my name's Randy Peterson. I work with the division If you have questions, I'm at the booth, I'm around.
My name is Gretchen Stye. I am the program manager for support services. I also work for the Division of Behavioral Health, and we'll just let our panelists introduce themselves now as well.
Good afternoon. My name is Megan Colwell. I am the Director of Community Engagement for Face It Together. So my role is focused on helping raising education and awareness on our peer coaching services and building those referral partnerships with organizations across the state.
I'm Pam Vidmeter, and I'm a psychiatric and family nurse practitioner from Lewis and Clark Behavioral Health Services in Yankton, and I coordinate our medication-assisted treatment program, doing some consultation with the other rural community mental health centers, and working in partnership with the division as we operate the opioid response grant.
Hello, my name is Gail Stahl. I am the founder, executive director of Hope House. We just opened a women's sober living in Huron, South Dakota.
I'm Wendy Barrett. I am the Rural Community Services Director for Interlakes Community Action. I supervise 14 counties here in East Central South Dakota. Today we'll be talking about the program that I supervise in Watertown called Watertown Transitional Housing.
Thank you. And just to give you a brief overview of what the Division of Behavioral Health kind of does, who we are the publicly funded behavioral health system. We have treatment services, including outpatient mental health services, outpatient and inpatient substance use disorder treatment services, support and recovery services, which is the primary focus of this panel today, and then prevention services. So this is just a broad overview of some of the support services we offer. We have partnerships with different providers for supported housing, for peer support services, and then intensive case management for substance use disorder.
And then one of the other things we wanted to share, since we have Pam on the panel today, is our medications for opioid use disorder, MOUD, or also we'll refer to it as medication-assisted treatment, MAT. We contract with providers to expand access to this service statewide, and we do that through office-based and telemedicine care. You can see the three listed on the screen, and this is all made possible through the State Opioid Response Grant.
So now we'll just get into some questions for our panelists. And we're going to be specifically focusing today on some of the rural resources, or how each of these providers reaches rural areas in South Dakota. So I know all of you said a little bit about who you are, what program you're representing today, but tell us a little bit more about your program and how you serve rural areas in South Dakota.
Hello? Oh, there we are. We're back on. My husband would say I don't need a mic, but I probably do today. So again, I'm Megan with Face It Together. So we provide one-on-one peer coaching support for both persons struggling with alcohol and substance use addictions, as well as loved ones. And for loved ones, we provide that support whether their person struggling is using our services or not. And we also don't put a label on what a loved one is either. It can be friend, family, coworker, neighbor, whoever is trying to understand addiction and support someone is welcome to that program. We are officed here, we're headquartered here in Sioux Falls, South Dakota. We've got another office in Colorado Springs, but again, we're a local nonprofit providing that support in person in our Sioux Falls office, but then we provide support to the rest of the state via video and phone. We were very fortunate to be set up for telehealth prior to COVID hitting globally, but it really helped put us into a position to be successful at that. You know, I'm sure you've heard several times today, COVID kind of reset our culture's approach to telehealth and comfortability with that. So we actually even took a deeper dive and looked at our data and our outcomes, which is really important to us. We are all about providing effective science-based peer coaching and making sure that we're staying true to the science and the data behind it. And so for our rural support, we were able to take a look at our outcomes between our video sessions, our in-person sessions, and our phone sessions, because we wanted to know, are we being effective as we're serving members in our rural communities across the state and across the country? We support members in 46 different states at this point, and some international countries as well. And we were very pleased to see that our outcomes between in-person and video were about the same. There was about a percentage point difference. So we know that our coaches are providing effective support. We're making a difference for people. Phone drops off a little bit, but again, you're missing that face-to-face component. But it's also a great way to start with someone too. Sometimes our members, you know, there's so much stigma surrounding addiction that they need to start with a little bit of distance. You know, that phone allows them to do that, build up a little bit of trust, and then can maybe move into the video option. For those in our rural communities who maybe don't have access to technology, you know, not everyone, contrary to popular belief, has a smartphone. Or has access to that. We were able to provide iPads and kind of station them in some of our rural areas, thanks again in partnership to the Division of Social Services. We appreciate that support. To make sure that if we're working with someone in a rural community and they don't have technology access, we've got partners in the area where they can go, they can check out an iPad, they can find a private space, and they can do a coaching session. Because again, we don't want technology access to be a barrier. And when you're living in a rural community, you have limited support options. You may have one AA group or one NA group, but that's also, you're interacting with your community members, and there's a lot of stigma around it. So not everyone feels comfortable having their car sit outside the meeting. So it's great to have kind of a one-on-one focused support piece that they can access pretty easily via video and phone. And it is, we provide that in a HIPAA compliant and a safe way to make sure that we're protecting their privacy.
Again, I'm Pam Van Meeteren, and my role here and what I'm talking about today is medication-assisted treatment. And we can't turn on the TV without having more stories about the amounts of fentanyl or opioids that are now being picked up in our state. It seems like the Midwest is always a little bit behind what we're seeing in the coast in terms of substance use, but certainly opioid use disorder, even within South Dakota, is on the rise. And what the goal of our medication-assisted treatment program is to make certain that regardless of where you live in South Dakota, regardless of your financial status, that there is access and ready access to treatment. And so we are operating a program that will allow for access, and our goal is within 24 hours after a contact is made. And then we are working again closely with the state, but also in partnership with other community mental health centers to either have a provider on the ground in different geographically located areas, or we will, through Lewis and Clark, provide telehealth or telesupport to make sure that treatment occurs.
Gail Stahl, Hope House. I want to say that I am not a treatment facility. This is a home that we opened. It's kind of a heart project for me. I recognized a need, and I told God for many months it wasn't me. I had no business doing this, but we're open. We've been open since March of 22. I have 7 beds, and I will take women. This is a women's sober living. We'll take women from anywhere, and we rely on rural resources to help us get the proper treatment and needs that these women have. So I will take women from anywhere if they're willing to fill out the application, and we'll get into that. But as long as they're willing to work their program of recovery, we're there to be a safe, sober environment where they can lay their heads at night. And I'm just so excited to be walking beside these women. And Huron is pretty centrally located, and this is the first sober living in Huron at this time. So thank you.
Watertown Transitional Housing was developed to bridge the gap between the justice system, addictions, and homelessness. And so, with the drug court program that they have in Watertown for Cottington County, a lot of the individuals leaving that program were either ending up homeless or they were returning to the environment that they got in trouble in the first place. And so we saw a need that there was, we needed somewhere for these individuals to go where they could, live safely and live soberly. And so that's how our partnership with Brothers and Sisters Behind Bars began. They offer the two houses. One of the houses is for men, and then one of the houses is for women. We also have some placements when those homes are full out at Midwest Bible Camp. So we have plenty of partners that provide the sober living spaces for us. We don't actually have any in-house. What we provide is the housing stabilization coach. And so when we get a referral from the court services, our housing stabilization will go out and meet with those clients. If they're accepted into the program, that's when the case management, the supportive services, things like that start, with the ultimate goal of getting these people stably housed and not back into the court system.
Thank you all. Would you just tell us a little bit about how somebody could get involved with your program? Is there an application or referral process?
Perfect. Anyone can reach out to us for peer coaching support for addiction. They can call, they can go to our website at wefaceit.together.org. There's a big green button at the top right-hand corner that says Get Started. You click that. We tried to make that pretty minimal because we don't want to overwhelm someone when they're reaching out in that moment. So it's basically just some contact information. That'll trigger our onboarding team, or we like to call it First Impressions, to reach out and give them a call. And we'll start by taking them through, what peer coaching is. How does that work? We want to make sure that they understand that they are talking to someone. They're going to get matched up with a coach who has that lived experience. There is no stigma or judgment in our organization at all. And it's something that we're really focused on tearing down. So we'll take them through peer coaching. They'll get a few assessments from us, pretty minimal. We try to keep, again, pretty light in that process where they're reaching out for help. But we will capture some information and some data. We'll do a second call and we'll kind of, again, find out what are your goals, what's going on with you. We want to meet our members where they're at. So we will take them in any stage, whether they're wondering maybe, do I have a problem, or whether they're further into their addiction journey. We'll focus on harm reduction. We have a lot of members who get started with us who are using multiple substances and they want to stop one. That's great. Let's start there. Let's start with making sure that they're safe and help them move forward on that wellness journey. And again, it comes back, we kind of call it our Match.com process, right? We have 13 peer coaches. Some are persons with addiction coaches, some are loved one coaches, some are dual coaches who have both sides of the experience. And we're trying really hard to match up not only on the substance and the addiction piece, but also a lot of our coaches have been incarcerated. Some have been homeless themselves. Some have, their own background and experience with abuse and trauma or mental health, and a peer coach isn't a counselor or a medical professional. So we're really upfront with people in that onboarding process on what the role of a peer coach is. So once we get through that process, and the biggest piece to break down to is the financial barrier. We're not clinical, so we can't bill through insurance. So we wanted to take that away. So thanks to partnership with the state and some other organizations, we have a ton of grants. So most of our South Dakota residents don't pay out of pocket for any of our coaching services, which is wonderful to be able to offer free coaching to people when they're reaching out in that moment of need and that moment of support. So from that first reach out to that first coaching session, we can usually get people in within about 4 to 5 days. If they call in and they're in crisis, we're going to throw all that out the window and we're going to get them connected to somebody, because again, that's a human being in crisis. We can work on the paperwork and get that taken care of later. For our referral organizations or our partners, really the same process applies. I always tell people the fastest way to get connected is on the website, clicking that get started button. A lot of our partners, when they're working with their clients, obviously with their consent through that process, will then just go ahead and plug in their information and just make note of, the organization that they're being referred from so that we can track that. Again, we want to keep it as warm, as safe and comfortable as possible for someone when they're reaching out for help in that moment. And it's so critical to be as quick as possible in that moment. So like Pam said too, when somebody reaches out to us, we want to get in contact with them within a few hours, at most 24 hours.
I've got my own. Access to treatment services really is relatively simple. It's as simple as making a phone call, and Lewis and Clark Behavioral Health can certainly be that contact number or the coordinator. The state opioid, the website also, Avoid Opioids, has a 1-800-HELP number which individuals can contact, and the state would connect as well. Referrals come to us from a variety of ways. Oftentimes, probably most often, clients self-refer, families contact us, but we certainly get referrals from primary care providers, addiction counselors, mental health counselors, sometimes Department of Corrections if individuals are involved with drug court or have had multiple incarcerations or arrests due to substance use. And so again, it's as simple as a phone call. We try to, I'll reiterate it again, we try to get someone to be seen within 24 hours of making that call.
Hello. To live at the Hope House, a woman will need to fill out an application, and then we do an interview process. They have to first and foremost identify as an addict. We do have guidelines and expectations. The women, to live in the sober living, since I'm not a treatment, they do have to care for themselves physically, mentally, emotionally, spiritually. We'll accept applications from anywhere. We've had referrals from parole, probation, recently the South Dakota Women's Prison, self-referrals, family referrals. The team and I, if you submit an app or through my website, submit a question, you will be reached out to within 24 hours, and we'll work together. Some of these ladies deal with life or death in the moment. Sober living is more what I foresee as a next step, right? And so maybe you're coming out of treatment or something like that. And so we're going to go through the application process and an interview process to make sure that we're a good fit for what you need to. And the best part is to welcome them home.
We prefer referrals directly from court services. There are occasions where individuals have heard about our programs through, friends or those that they met while in prison, and sometimes they'll reach out. We'll always directly go to their court services officers, though. We really stress the importance of the individuals being ready to partake in the program. We really heavily rely on the court service officers and their opinion of where this individual's at in their recovery journey, and if they're ready for an intense recovery program like this. Because if they are not ready for a program that is so client-led, then it doesn't do them any good, and it doesn't do any good to have them taking up a place on a program that someone else could be using that is ready for that next step. So when a referral comes in, our housing coach will meet with the court services officer and then meet with the client for who the referral is for. Do an assessment, make sure that they're a good fit for the program, that the program's going to be the best thing for them, and that they'll fit in with the program and everyone else that's currently in the program. And then if they're accepted, we'll get them moved into one of the recovery housing situations. They do have to be sober for a number of days before we'll allow them to join others in those living environments, which usually isn't a problem because they're usually incarcerated before that. So they don't have access to that stuff anyway. And then, from there, as long as, they're following their court services requirements and case management requirements, they're allowed to stay in the program for as long as they need.
Great, thank you all. And next, could you just give us a brief overview of what somebody could expect involvement in your program to look like?
I actually get this question a lot because people are looking for, what is the curriculum, what's the treatment program, and that's not how we operate at all. Like I mentioned earlier, it's all one-on-one, and it's very personalized and unique. So it truly is what's going on with you, what are your goals. I mentioned those assessments earlier when they get started in our onboarding process, and one of them is our Recovery Capital Index. That's a particular assessment that we created, had validated, and published. And it is getting scores that they take on onboarding and then every 30 days in their coaching process. And it's gathering scores on personal, social, and cultural capital. It doesn't even have a single question on addiction or usage on that particular assessment. We want to approach our members very holistically. We're looking at the whole person. Addiction is one piece of what's going on with them. It doesn't define who they are as a person. So we want to make sure that we're addressing them as a whole person. So what happens is they build these goals with their coaches, and most of our members do weekly sessions. However, if they need a little bit more support in the beginning, we want to be flexible. Again, meet them where they're at. They might do daily sessions to start. It is truly between our members and our coaches what that frequency looks like and what they're comfortable with. And then they're going to start bringing in those scores and assessments into the process as well. It's great because we can pull out, a couple scores that tie in with their goals, and we can graph it and give them a really tangible view. Sometimes when you're working so hard, you can't see the forest for the trees. You don't know the progress that you're making. So to be able to pull that out and say, one of your goals was your relationship with your significant other, and you started here at the start of coaching, and here we are 60 days later, and look at how far your score has come. And so to be able to show a tangible result of that to help really encourage someone and keep them going is very helpful. And then it also becomes a roadmap for our coaches too, because a lot of times they'll identify areas that scores have dropped or dipped, and they haven't even been verbally addressed in the coaching session. The other key thing for our members working with our coaches is navigating to other resources. Someone starts with us and maybe they've gone through treatment before, maybe they haven't. Maybe they've been seeing a counselor, maybe they haven't. But I had one member who said to us, it was a great way to calm the chaos and really understand where I was at and what I wanted to go forward with. So our coaches can help them build that wellness team. If treatment is where they need to be, we can help navigate and connect them to a program, inpatient, outpatient. If they're not seeing a counselor, we can work on the barriers to that. We can get them connected to a counselor, do that warm handoff. If they're in a financial crisis, housing crisis, food crisis, we can help connect them to resources to that. So I tell people it's kind of like getting a life coach with a specialty in addiction, because we want to help with whatever is stressing them out. Yes, we're there for the addiction piece, but we're also there to help with their overall wellness. For our loved ones, obviously, it's still one-on-one, it's still personalized and unique, but loved ones tend to have some overarching themes coming up in their coaching sessions. So we work a lot on understanding addiction as a disease. We work a lot on compassion fatigue, really taking care of themselves. That coach, that loved one coach, is there for that member. If we can get their person struggling with addiction into our coaching program or into another coaching or another treatment program, that's awesome. They're going to get their support, but the loved one coach is there for that loved one. It's their advocate. So we're going to work on compassion fatigue and self-care. We're going to work on positive communication. We're not a tough love or intervention style organization. We're going to work on understanding, enabling how to set boundaries. We're going to try to give them all the tools in their toolbox so that hopefully they're then modeling that behavior change, and then we can hopefully get their person into whatever recovery or support program that looks like for them. And again, it becomes a true partnership and a relationship with their peer coach. All of our coaches are employed by us, trained by us. They go through our certification process. They go through some national certification processes as well. We have a quality assurance program with our coach supervisor that's then informing our continuing education. So again, I'm going back to that safe, effective, science-based peer coaching and support.
Okay. The medication assisted treatment program really has several components to it. First of all, oftentimes someone coming to us is a bit uncertain about really whether or not they're ready to take this next step in their lives. And so the initial part of what we do, or the initial step, is to do an assessment, which is usually done by a certified addiction counselor or a nurse practitioner, to determine specifically the severity of the addiction and what level of care is needed. Generally, the use of medication comes in when an individual would meet criteria for either mild or severe use disorder. And at that point in time, we would determine the direction of treatment. Of course, this is always done in collaboration and partnership with the client. We may have a direction that we may think is best, but certainly compliance and buy-in from the client is going to only occur if they're in agreement with the plans that we develop. There's 2 different medications that can be used for medication-assisted treatment. Both of them have some uniqueness to them, so the advantages and disadvantages of each would be weighed out. Most commonly, the 2 medications that we use are Suboxone. Suboxone is a partial, for simplicity, it's a partial opioid, but it also has a blocker in it. So it really alleviates craving, but at the same time, that blockade mitigates the ability for someone to overdose or to, even if they use another opioid in addiction to the Suboxone, where the goal there is to prevent respiratory compromise. Vivitrol, on the other hand, is a monthly injection. It completely blocks the ability for the opioid to enter into the brain cell. So therefore, the individual will get absolutely no effect if they take opioids. Now, of course, some disadvantage of that is if someone actually has a real acute care or acute pain need, such as a car accident or surgery, skilled professionals, however, can look at alternatives for managing that pain. One of the things that is perhaps a bit unique to what we do in comparison to maybe a practitioner in a medical clinic or other providers is that we really adhere to the fact that this program is medication-assisted treatment. And therefore, we believe that still a strong component of treatment and recovery comes from being involved with the other addiction components of counseling, peer support, looking at mental health and other resources to navigate the psychosocial needs of the individual. My role is maybe pretty simple in all this. I prescribe the medication, but the hard work comes from the counseling and the client's commitment to really fully working towards recovery. We do, again, with client buy-in and support, have some ways that we build in some accountability. We do routine UAs, partly to, unfortunately, in this world of diversion, make sure that the client is actually taking the Suboxone, and also to make sure that there aren't other substances involved. As we all know, working in the field of addiction, it's rare to have a single substance addiction, and generally poly addiction is part of what we deal with. Again, the medication-assisted treatment, though, is really targeted at the opioids, which ultimately cause death when they're used in excess. We also use some contingency management as part of our program, and we do this not by, the contingency isn't based on a clean UA or perfection in terms of recovery. It's really, the contingency is the fact that they showed up, that they're continuing to engage with the counseling, and we do look at that. And certainly we'll make other referrals to other services, mental health. A lot of times clients haven't taken good care of their medical needs. Certainly some addiction occurs with opioids due to chronic pain, so we recognize that all that needs to be managed and addressed as part of their treatment as well.
A day in my home can be different for every woman. Usually, you know, depending on when she got there and how we're doing, the women are required to have a job, seek treatment programs, go to a meeting. Usually they're getting up, going to work, and doing the recovery meetings in the evening. If a woman's just moved in, she's job searching. We're walking beside her to get the proper documentation she needs in order to get a job. I guess it just really depends on how things are going. And we're just a family. These are guests in our home and they're supporting one another. And me and my board members I have a very active board, and we're walking beside them through anything they might need. And some of these women, I would say 90% of the women that we have helped so far come to me with no documentations, no way to get there, don't know what the next step is. So we're just a resource for them, and we point them to their, hey, you need to go here, and they can help you do that. And so, yeah, it's just walking beside women on a daily basis. We also do random UAs because that's part of accountability, and that's what we're doing at our house. And so, yeah, it looks different every day for us.
Yeah, our program is very different for the experience of each individual client as well. When they come to us, a lot of times they're at different stages in their recovery. How much case management they need, how much intervention they need is all determined upon their assessment. So typically, while they are staying in these homes, they do have certain chores and expectations that they need to do, maintain their living spaces, things like that daily. They will be meeting with our case manager, our housing coach, as often as they need to. Some of them it's 3 times a week, and some of them it's bi-weekly. So it just kind of depends what they need. A lot of them, being involved with the justice system, do have several other individuals in their lives that they do need to meet with as well on a regular basis. So a lot of times they're attending their drug court classes, they're attending their parole meetings, their probation meetings, they're attending AA classes, NA classes, right? So their days are usually pretty packed in the beginning with those support services. Sometimes we see people in our home for 6 months, and towards those longer stays, their schedules usually look a little different. They require less supportive service meetings. They require less case management. Usually they've found a job and they're saving up for their permanent place to go. So it just kind of depends. Depends what level of need they're at. We take everyone with a case by case and we adapt to them.
Thank you all so much for just answering some of these questions and for sharing more about your program. For the sake of time, we'll kind of wrap it up here, but I know if you have further questions, you can reach out to any of these individuals, reach out to us at the Division of Behavioral Health, and we can get you connected with anyone on this panel. And I just wanted to add that, the reason we're focusing on these support services is because everybody has a different path to recovery. It's going to look a little bit different for everyone. So, all of these services can just help to meet people where they're at in their addiction and on their recovery path. So thank you all for joining us today to learn more about these programs.
Does anybody have, we have a few minutes. Does anybody have a question they'd like to ask of the panel? Oh, there's questions online, Lily? Okay. Yeah. Hold on, we got one in the room. Go ahead.
Okay, thank you so much for sharing so many valuable experiences. I just was wondering, I heard the session before, and I think it's wonderful to hear that they have this network of coalition meetings for the substance abuse prevention effort, and for the suicide prevention, there is an interagency meetings. So I was wondering whether all of you part of that sort of like interagency meetings or coalition meetings that, and then if you are part of that meetings, like how often you meet each other and what is actually that you're sharing to each other, because I just feel like that is so important as we all navigate the system. Thank you.
Gretchen can help me here, but I am part of the share group, and we meet once every 3 months, I think it is. And I'm actually presenting next week to our share group. So yeah, there we go. I've never met these ladies, but I'm very, and then I also personally, we have a community Huron involvement meeting that meets once every 3 months too, and I attend that too, so.
We are also a part of the Division of Behavioral Health's share recipient funding. So we do partake in those meetings. We're presenting next week as well. And so we get to learn about each other's programs because we all kind of touch a different area. So that's fascinating. We also do take part in the community meetings that go on. Cottington County especially has a lot of interagency activity. And so I always have me or one of my staff that go to those just to make sure everyone stays up to date on what we offer. And we're aware of what everyone else can offer as well.
I'm not personally involved with the networking group that you referenced that had been discussed. One of the things that I do in my role, however, is meet or make contact regularly with the other providers at other community mental health centers across the state, and then also participate in the clinical directors meeting for the community mental health centers. And we meet, generally it's every 2 months.
I would say ditto to a lot of what the other ladies said. We also participate in multiple collaboratives across the state. That's a big part of my role, is traveling and making sure that I am available for those meetings, either via Zoom or in person if possible. Because you're right, the more we connect with each other, the more we share our resources, the more we build those warm handoffs, the better we are as a addiction support recovery community to help lift up our community members in South Dakota.
Thank you for that. There are some couple virtual questions coming into the Q&A here. I think we have time for maybe one or two. The first one here is, do you see many success stories after they stay at all of these facilities? So
I'm going to just speak to that real quick, and I'll give you a couple very quick examples. My first client was a pregnant woman, which is not exactly how you want to start medication-assisted treatment, was referred. She has her little baby, her baby that we followed her through pregnancy will turn 3 this summer. I wish I could say this individual has walked just kind of a straight and narrow path. That hasn't been the case, but she has stayed out of jail, prison, which had been a major issue. She's maintained custody of her kids. She's maintained employment. We keep her medications in her office. She comes in 2 to 3 times a week to fill her own pill bars, so we have regular contact. Second young man, I literally went to his pickup truck to meet with him because he wouldn't come in. He is now a junior at SDSU as a nursing major and in complete recovery. So yes, there is success.
Thank you for that question, because I was really sad we didn't get to it. Success for our guests and for our program, or not our program, but our home, is honestly measured every day differently. Success to some women is not using when you really feel like using. Success is getting a job. Success is having, so the children don't stay in the home. Oftentimes they're placed either in foster care or with other family members. One of our women has 4 children who have never had a meal together. Success is sitting at the table and having a meal. Success is coming to me when you were facing 30 years in prison and being sent away for just 3 years, but working for 3 months to build a good program. And you know what? You have to pay for your consequences, and then success is being paroled to the Hope House, right? Success is 10 minutes ago, I had a lady that I took from prison on Friday. She got a job and she starts tomorrow. That's success for us.
They're so hard to pick, right? We have members who have gone on to start their own businesses and are so engaged and involved in their community now as business leaders. We have some of our members who now sit on our board. Some of our members are now coaches, helping others. One particular woman that I'm thinking of had been in and out of treatment 4 times, struggled with meth for many years, had lost custody to her children. Traditional treatment didn't work for her, but after working with our coaches for a year, she was in a much better place. She was employed. She just went up for a hearing to get her custody of her kids back, and it's going very well. So there's so many instances, and I think it's so great to hear the success stories from all the other programs too, because when we all work together to really layer that support around our individuals, amazing things can happen.
Go back on that. Success does look different for everyone, especially when you're working with individuals with addictions. Expecting a successful outcome for everyone the first time is not reasonable, right? A lot of times they're going to fail multiple times before they succeed. And so that's something I always tell my staff to keep in mind when they're looking at that data, right? Yeah, you had 4 out of 12 people succeed last year, but those 5 people that came in and they reoffended after a week and they ended up back in the same place. Maybe next time when they come back they will be a success. So to focus on those positives in those cases that do turn out, because any success in this with individuals going through this challenge is a success.
Awesome. Thank you guys so much for those amazing stories. We are unfortunately out of time. I just want to thank the panelists again for your guys' time today and being here. For everybody else as a whole, if you guys would migrate over to this room, we'll have our day 2 wrap up here in a few minutes. And yeah, that'll be the end of the conference. So thank you guys so much.